I'm Danny Indelicato. I'm one of the co-moderators for this symposium with Dr. Sid Laskar. And the topic of our talks today will be the role of surgery and radiotherapy for Ewing sarcoma. We have a really good group of speakers providing a diverse set of viewpoints on the management of this disease. I'd like to remind the speakers to provide any disclosures or conflicts of interest prior to their talk. And at the end of all three talks, we're going to present a few cases, and I'm hoping for interactive discussion from both the panel and the audience. The first speaker today is Dr. Felipe Calvo from here in Spain. Thank you.
Thank you very much, Dr. Delicato, and the organizers for this opportunity of reviewing for you special techniques in radiation therapy in the management of Ewing sarcoma. My topic is intraoperative radiotherapy and brachytherapy, which are interventional radiation therapy modalities that try to improve the understanding that we as radiation oncologists we have of precision medicine. Precision medicine for us is precision dosimetry and many other things. But we have to start by precision dosimetry and then molecules and then markers and whatever else you can think about. I have no disclosures. And the idea for me is to review very briefly the basics of intraoperative radiotherapy and brachytherapy, and then the data that is published, has been published in our century, 21st century data, and then I will review with you my own personal experience in my institution, and then make some final comments. Intraoperative radiotherapy is very simple to describe. It's radiotherapy during surgery, at the time of surgical procedures. And it has been expanded in human oncology because of normal tissue protection. We are able to displace many normal tissues at the time of surgery and protect them from the effect of radiation therapy. In the case of pediatric tumors, this is important, and external beam radiation therapy inevitably has to treat many normal tissues in different levels of radiation. And another positive feature of intraoperative radiotherapy is that we treat surgical margins, tumor beds, post-debulking areas, minimal residual disease. So that is also an important biological feature for intraoperative radiotherapy. In terms of promoting the technique, I use the expression guided. Technology in radiotherapy is fashionable and attractive and appealing if it is beautifully guided. Well, in this case, it's guided by the fingers of the surgeons, by the eyes of the radiation oncologist. It's difficult to imagine a better way to guide the radiotherapy in the human body. This is important, the past is important. Brachytherapy and electrons, both are radiotherapy techniques. Both are very different in terms of dosimetry. Electrons are able to treat homogeneously thickness of tissue from 0.5 centimeters to 2.5 centimeters with different energies, but homogeneously. You treat the thickness of the tissue and nothing afterwards. Brachytherapy is able to treat only the surface of the area of contact between the isotopes and the tissues. So if you want to treat a certain thickness, you have a very unhomogeneous dose distribution in the area that you have selected. So both are intraoperative, both are very different in terms of dose deposit in the tissues. This is just to remind me that radiotherapy is well established in the management of Ewing sarcoma, but a component of the dose can be delivered intraoperatively. So if the patient is going to need surgery and radiation therapy, there is an opportunity to discuss whether that patient can receive a component of the dose, highly precise component and with normal tissue protection using one of these special technique. Let me review for you brachytherapy. Brachytherapy, I am not an expert on brachytherapy because I am an expert on electrons. So, but I have enough culture in radiotherapy to describe for you the brachytherapy issues. Brachytherapy has different ways to reach the area that you want to treat with isotopes. One are interstitial, you put the isotope in the tissue itself. Another is flaps, you put the isotope in a certain surface of plastic and you make a contact with it, or you do molds. It is well described the use of molds in Ewing sarcoma. This is one of the papers that I have selected for you, relatively recent. Small numbers, but this is the world of intraoperative radiotherapy. We don't have large cohorts of patients. It's a way of, it is a very personalized type of treatment. Nice 5-year control, long term, and of course, these Ewing sarcomas are being treated in the context of sarcomas in general, pediatric sarcomas in these cases. External beam radiotherapy can be used or omitted in this type of decisions in which you are personalizing the treatment. You can deliver the full dose with intraoperative brachytherapy, or you can use a component of the dose as a boost and then external beam radiotherapy. And this is probably the best collected data from brachytherapy, intraoperative brachytherapy high dose rate, which is the Memorial Sloan Kettering, and it's molds most of the times. In their large cohort of patients, a few of them were Ewing sarcomas. And when I reviewed the data in depth for you for this meeting, I was not able to discriminate what was the outcome of specifically Ewing sarcomas after intraoperative brachytherapy. They have updated that data recently, more in detail, using exclusively, reviewing exclusively Ewing sarcoma patients. And here you have the data. They have very good local control altogether, only 2 local recurrences, and the data is mature, the follow-up is very large. And many of the patients were high-risk patients with not completely resected tumors and more than 8 centimeter diameter lesions. In brachytherapy, I'm going to make only 2 additional comments. One is that it is very elegant to treat difficult and complex areas. You can do molds and many special devices to bring the isotopes nicely to the tumor bed area in cavities and in difficult anatomic areas of difficult access. High energy electron beams is my area. It has been used for many, many years. I have here a collection of data. And what I want to call your attention is that most of the Ewing sarcoma patients that have been reported, they are part of a large cohort of pediatric patients with sarcoma data, and it's difficult to look at the specific results using intraoperative radiotherapy. In this case, this is a well-known German Heidelberg experience in which they have all the patients alive and very good results. These are Spanish results. We were able to put together a pool analysis from 3 different institutions in Spain with using intraoperative electrons and a cohort of patients with Ewing sarcoma and rhabdomyosarcoma. We used those 2 cohorts because they both were chemosensitive and they were need surgery and radiation therapy. And in our case, 37 patients were treated. Most of them had recurrent disease. A large cohort of them had recurrent disease, and the results were good enough in terms of local control and survival. We were able to find some prognostic features. Primary disease was positive, good responders was positive, and margin status was also a positive feature for outcome long term. Intraoperative radiotherapy, both in brachytherapy and in electrons, is a way to also intensify the dose. We use a component of the dose, but together the component of the boost plus the external beam, there is a level of escalation of the dose. And we find a new feature that was not easy to see with external beam fractionated radiotherapy only, which is neuropathy, peripheral neuropathy. It is not uncommon to see in the intraoperative literature description of peripheral neuropathy after the use of intraoperative electrons or brachytherapy as an escalation, as a dose escalation approach. This is something special. Extracorporeal intraoperative radiotherapy. It was described by the Japanese colleagues, and our German colleagues, they did also this type of approach. They take the bone, they irradiate the bone massively, and they put the bone back. And this has been explored and abandoned because long-term side effects in these patients, but it was a very imaginative way to treat patients. And finally, our own experience. In Gregorio Marañón, which was my former hospital, if a patient with Ewing sarcoma reached the moment of decision of local therapy and was a candidate for, because of the protocols, for surgery and external and radiotherapy, then we discuss whether at the time of intraoperative resection we can find a favorable situation to do intraoperative radiotherapy. In 25 years, we treated 17 patients, and most of them were non-extremity patients, were Ewing sarcomas of the pelvic area or pelvic region, some intra-abdominal, some thoracics. So were type of surgeries that was not extremity resection type of maneuvers. Most were very large tumors, more than 8 centimeter diameter, and a proportion of them, not a minor proportion, a proportion of them were recurrent. Extended resection was performed in the vast majority of them, and I'm bringing this example of extended resection in a very large Ewing sarcoma of the rib, and marginal and intralesional was the less frequent feature. Preoperative or postoperative radiotherapy was used, not in all patients. Some of the patients had previous external beam radiotherapy, and the possibility to re-irradiate was minimal with external beam. So all the dose was delivered intraoperatively. We used large applicators. The tumors were large, the tumor bed were large, so the size of the dosimetric area that you want to use has to be large as well. The energy is good enough to treat these patients, the energy of the beam, and the dose was 10 centigrades in the majority. This is the last update I have done. We have 10 patients alive and control. We have 3 in-field recurrences, and they have to do with cavities, either abdominal cavity or thoracic cavity, and one was an extremity patient. In long term, we have patients alive, and we have long-term side effects, specific side effects in the area of boost or intraoperative radiotherapy that have to do with bone fracture in the extremity, bone fracture in the ribs. So things that we were not, we didn't see with another approaches. We did a case of extracorporeal. The patient had a good evolution, but had disseminated disease in the long term. This is the semi-final slide. Intraoperative radiotherapy, both electrons and brachytherapy, are feasible, can be done, not especially toxic. If you see toxicity, you have to be careful with the previous radiotherapy, with the radiation procedures and so on. The technology is very nice. We have now linear accelerators miniaturized, that they fit well in a busy operating room. So it's not something that it's creating more problems in the operating room. And this is my final slide. So altogether in this presentation, I have reviewed 90 patients with reported with brachytherapy and high local control, with electron 70 patients with a high local control, intraoperative radiotherapy, dosimetric optimization, and this, Dr. Indelicato. Spaniards, we are very, very emotional people. They were my masters. I was trained in Philadelphia, and Julio Danjo and Audrey Evans and Luther Brady teach me many things, but not intraoperative radiotherapy. Thank you very much.
Thank you, Dr. Calvo. If you would like to sit up here, Dr. Calvo, for the panel later on, and we're going to hold all the questions to the end when we discuss a few cases. I'd like to bring up on stage next Dr. Dimo Andreo from Germany. If you could set the timer at 20 minutes to allow us questions at the end. Go ahead, Dimo.
Yes, thank you, Danny. Thank you for the introduction, and I'd also like to thank the organizers for allowing me to give this talk on the role of surgery in Ewing sarcoma with or without perioperative radiotherapy. These are my disclosures. Quick question before we start. How many of you in the audience are surgeons? Excellent. I was afraid I would be the only one, so please back me up. We have a lot of radiation oncologists here. I need your support today. So, we all know this. The problem with local treatment in Ewing sarcoma is that the Ewings tend to get really large before we find them. So they infiltrate or contaminate a lot of important anatomical structures, meaning that either surgery or radiotherapy is going to be associated with a long-term morbidity, and it's challenging to do local treatment in these cases. And of course, we also know that neither surgery or radiotherapy alone can heal the patients long-term. We also know, however, that chemotherapy alone also is not sufficient to lead to long-term remission of the disease. We need the combination of both systemic and local treatment aspects. In Europe, at least at the moment, surgery is considered to be the treatment of choice, if feasible, for the majority of patients with Ewing sarcoma, because the data that we have seem to show that there's a slightly higher risk of local recurrence if we use radiotherapy. However, you will see here that radiotherapy is used when we cannot do surgery, and I'll come back to this point in a minute. Although, however, surgery is a very important local treatment modality in Ewing sarcoma patients, If we look at the objectives of the two new large intergroup Ewing trials, which are going to be opened in Europe in the next couple of weeks and months, we see that there are a lot of important and very, very interesting questions regarding the optimization of chemotherapy, regarding quality of life, regarding biological markers, and so on and so forth. We also see that there's going to be a randomized question on optimal radiotherapy dose in patients with different risk constellations in Ewing sarcoma, but there will be no question whatsoever on surgical treatment, either randomized or even prospectively. Now, I'm guessing most of you are thinking, okay, yes, of course, so we don't need any questions on surgical treatment because we have answered all questions regarding surgery and local treatment in Ewing sarcoma, but that's not quite the case. If we look at the European data, which have more or less influenced our philosophy for Ewing sarcoma, we see that patients treated with radiotherapy or a combination with surgery or a combination of surgery and radiotherapy tend to have a higher overall survival probability compared to patients treated with radiotherapy alone. So that's why in Europe we are strong advocates for surgery in Ewing sarcoma. However, if we look at the data from our colleagues from the other side of the pond, then we see that although the combination of surgery and radiotherapy appears to be slightly better in local control, radiotherapy alone appears to be at least as good, if not slightly better, in terms of patient survival compared to surgery or the combination of surgery and radiotherapy. Now, of course, all of you will be probably asking themselves right now, okay, why do we have so different data on local treatment modalities? And the answer is rather easy. All the data that we have on local control are retrospective analysis of prospectively collected data or even of cohort data, meaning that the evidence that we generate is very poor because the indications we use to treat our patients influence the outcome of these modalities. And that's what I was alluding to before. If in Europe we only reserve radiotherapy for the worst possible Ewing sarcomas, then it's quite easy to understand why our patients undergoing radiotherapy have a worse outcome. And if we do surgery in the smaller, easier tumors, then of course these patients are going to have a better outcome. We need to keep this in mind for the remaining of the presentation, for the data that I'm going to show you, because this affects a lot of things. So taking this problem into consideration, the most obvious question that I have asked my first mentor when I was a resident in orthopedic oncology is, okay, if we don't know what's better, why don't we do a randomized study between radiotherapy and surgery in patients with Ewing sarcoma? Unfortunately, for several reasons, such a study is considered infeasible because most people believe that surgeons or radiotherapists or even oncologists are not going to be willing to include patients in this randomized setting. And indeed, we do have trials in bone sarcoma in a randomized setting for local treatment, which have failed to complete their intended accrual and had to close early because they didn't get enough physicians recruiting their patients. So in the absence of randomized evidence, we have to see what sort of retrospective evidence we have to support the use of surgery in Ewing sarcoma. And there is a very nice systematic review that was published in 2016 showing the current evidence up at that point for radiotherapy versus surgery. As you can see here, radiotherapy was associated in this systematic review with a slightly higher risk for local recurrences compared to surgery, but there were no differences in overall survival. And more importantly, if we systematically evaluate the quality of these studies, we see that all studies that were available at that point were considered to be of a very low quality, and they had a very high, serious risk of bias, which is something that we need to keep in mind. There was also a so-called network meta-analysis published in 2020 showing that compared to surgery alone or the combination of surgery and radiotherapy, radiotherapy alone was associated with a slightly higher local recurrence probability, but again, there were no differences in event-free survival probability of these patients. Now, this network meta-analysis includes some novel and interesting aspects of statistics, which allowed the authors to calculate the probability each treatment modality would have to be the best for the patients in Ewing sarcoma, and the authors found that with the data that they have, surgery alone was most likely the best treatment modality for Ewing sarcoma patients, both in terms of local and systemic disease control, even better compared to surgery and radiotherapy. But this is a little difficult to understand, because if you do surgery and add radiotherapy, you would not expect to have a worse local control, at least. And if you go back to the studies that this meta-analysis included, then you see again that we have retrospective studies with very, very different cohorts of patients that were analyzed, and more importantly, the systemic treatments that these patients received are very different. And we know now today that patients undergoing receiving the standards of VIDA or VDCIE have a better prognosis than patients receiving VACA or EVAD. And these are patients that are pulled together here. So we need to be mindful of the data that we use in our meta-analysis when we try to make a sense of what local treatment modalities actually achieve. Contrary to what these two reviews and meta-analysis have shown, there is an argument for the role of perioperative radiotherapy in Ewing sarcoma. A couple of years ago, Jeremy Whelan published this very interesting study analyzing the survival of patients with Ewing sarcoma depending on the philosophies of the centers where they were treated. In the ACES 92 study, both patients from the United Kingdom and from the mainland Europe were registered. And after the study was completed, the study investigators found a very worrying trend, namely that the patients treated in the United Kingdom had a significantly worse event-free and overall survival probability compared to the patients treated in mainland Europe. And this worse survival did not appear to be caused by more metastasis as first events, because the rates of metastatic disease were pretty much equal between the two groups. But the patients treated in the United Kingdom had a significantly higher probability of local relapse of 22% as first event, which is really, really high, compared to patients treated in mainland Europe, which had only a local risk of 7%. Of course, the authors also examined whether there were differences in tumor characteristics or in patient characteristics. This was not the case. And the only difference that they found was that there were differences in philosophy of how local treatment in these patients was performed. And as you can see here, patients treated in the United Kingdom had much more commonly surgery alone or radiotherapy alone, compared to patients treated in mainland Europe, who much more often received both surgery and radiotherapy. Which is why our colleagues in the United Kingdom are now strong advocates of perioperative radiotherapy in Ewing sarcoma, and indeed have done a lot of research and analysis to its role. And another very interesting paper on the role of perioperative radiotherapy was also published based on the data of the Euro-Ewing 99 study, including 599 patients who all had standard risk Ewing sarcomas undergoing surgery after chemotherapy and having a good histological response to neoadjuvant chemotherapy. So patients where we would usually say these patients are not the typical candidates for postoperative radiotherapy. And this meta-analysis showed, this analysis showed that additional radiotherapy to these standard risk Ewings with a good histological response to neoadjuvant chemotherapy appeared to be associated with a better local control compared to no postoperative radiotherapy. And the patients that appear to have benefited the most from postoperative radiotherapy were patients with a complete necrosis of the tumors. And this is actually something that we can understand. In the past, we have said, if the patient have a complete necrosis, we don't need radiotherapy if we've done surgery. But if you go back to this tumor and see how a typical Ewing, with a good response to chemotherapy, develops, then you can see that at the time of when we are going to do surgery, the amount of tissue surrounding the tumor is much less than the case here. For instance, if you can see the abdominal muscles are contaminated here, But if I do surgery here, I will most likely not address the muscles in this area. So there may be some residual cells remaining in situ if I do surgery after a very good response to chemotherapy. And if I do postoperative radiotherapy in these patients, I may have the possibility to rescue some of the patients that would go on to develop local relapses. On the other hand, this meta-analysis also showed that not all patients benefit from perioperative radiotherapy. For instance, patients with axial tumors appear to benefit from it, but patients with lymph tumors not. So it's still, again, a little of mixed messages. We need to find out which patients benefit the most from perioperative radiotherapy, which is something we don't know. And in order to answer this question, we have started trying to do more focused analysis of not all patients treated in all studies, but of patients, as is the case in this study, with localized pelvic Ewing sarcoma, treated all with one chemotherapy protocol, namely the Ewing 99 protocol. And the first analysis of these patients with localized pelvic Ewing sarcomas that we did was a bit surprising for us in Germany. We saw namely that the combination of surgery and radiotherapy was better than surgery alone, but in this European study, patients undergoing radiotherapy only appeared to have more or less the same outcome as patients undergoing the combined treatment. That was a surprising finding for us. So we're starting, considering whether we got it all wrong, whether our colleagues from the other side of the Atlantic may have been right in advocating radiotherapy in these patients. But during the analysis that we were doing, there was a study coming out from the Scandinavian sarcoma group on the differences in prognosis between patients with sacral and non-sacral pelvic Ewing sarcoma. And what this study showed very nicely was that despite the fact that sacral Ewing sarcoma is treated with radiotherapy alone much more often compared to patients with non-sacral Ewing sarcoma, patients with sacral Ewing sarcoma still have a trend for a higher local control and a significantly higher overall survival probability compared to patients with non-sacral pelvic Ewings, meaning that sacral and non-sacral pelvic Ewings appear to be two different sets of diseases that we need to consider separately. For that reason, we went back to our data and found that this was the case in our cohort as well. Patients with sacral Ewings were mostly treated with radiotherapy alone, but even in our data, they still had a lower local recurrence risk and a higher overall survival probability compared to patients with non-sacral pelvic Ewings. We therefore excluded patients with sacral Ewings from our analysis, and our results were at least more in line with what we would expect in Europe, namely that surgery and radiotherapy were better. Now, our analysis did not answer definitely the role of radiotherapy in these patients. I think Matt is going to say something about the limitations of this data. But what we did show here is that if patients with non-sacral pelvic Ewing sarcomas undergo surgical treatment, then they appear to benefit from additional radiotherapy, both in terms of local control and in terms of overall survival probability. And this was also conferred in several subgroup analyses, for instance, in patients with wide margins and good histological response to chemotherapy. Again, the patients where we would traditionally say they should not receive additional radiotherapy. Still, these patients with non-sacral pelvic Ewing sarcomas appear to benefit from the addition of radiotherapy in their local treatment. And the multivariate analysis, again with several known prognostic factors, confirmed this finding that in non-sacral pelvic Ewing sarcoma, the combination therapy is better than surgery alone. So, to conclude, at the moment, surgery appears to be associated with a slightly higher local control probability, and at least in Europe, it's considered to be the treatment of choice in most patients with Ewing sarcoma. However, we also have seen that there are a specific group of patients who appear to benefit considerably in some cases from perioperative radiotherapy, such is the case in non-sacral pelvic Ewing sarcoma, patients with larger tumors, or patients with complete histological response to neoadjuvant chemotherapy. However, we do need to keep in mind that we cannot say that all patients with Ewing sarcoma undergoing surgery should receive additional radiotherapy, because the combined treatment is associated with a higher long-term morbidity. And we need to keep in mind that the functional outcome of the patient is equally important when we achieve so good prognostic outcomes as we have in the last studies. As a result, we do need more data, and more importantly, we need high-quality data going on forward to decipher the optimal local control strategy in patients with different risk constellations. And with that, I would like to thank you for your attention.
Thank you very much. We'll move on to the next talk. Yes, please come on. And it's my pleasure to introduce Dr. Matthew Grayson from the St. Jude Children's Research Hospital. And he would tell us about his views on external beam radiation therapy for Ewing sarcoma. Matt?
Well, thank you very much for the opportunity to get to chat here on our last day in beautiful Barcelona. And it was really pleasant to have a surgeon that welcomed radiotherapy so much in the postoperative setting. So we don't always used to get to follow groups like that. So that was nice. So hopefully I'll be as gracious, and we'll talk a little bit about definitive radiotherapy. And I don't have any disclosures related to this presentation. So it's always useful to kind of look at where these sites of diseases occur in Ewing's. It's a relatively rare tumor, even in North America, where there's maybe a little bit over 200 cases a year. Surgical expertise is really critical for that, and that seems to have gotten quite well disseminated across many centers, both in the U.S. and really across the globe. Sometimes very difficult and morbid resections dictate that radiation therapy is the preferred treatment. And then, like we just heard, there may be a number of scenarios where combined treatment really is the appropriate approach. I highlight just a couple of sites just so you can sort of see the percent cases. Really, as a radiation oncologist, we probably spend more of our time focusing our efforts on skull, spine, and pelvic sites of disease, and the occasional scapular site of disease, at least in our institution. Improvements in limb salvage have really dictated that extremity sites and the excellent outcomes that we just talked about really are the purview of the surgeon, but cases like this large pelvic mass involving multiple bones and around the acetabular complex often warrant radiation therapy as the primary modality. And then these other cases, like I think we'll discuss in some of our cases at the end, where tumor resection may leave an involved margin, or there may be poor histologic response or other features may warrant a combined modality approach. I think the other thing, just real quick to kind of focus on, since we've been talking about radiation and pediatric diseases here at SIOP, is there's definitely a selection with a surgical preference across the trials, both in the U.S. and in Europe. But nonetheless, about 50% of the patients, particularly in the U.S., end up receiving definitive or adjuvant radiation. The patient population for Ewing sarcoma is older than what we see in rhabdomyosarcoma or Wilms tumor or other soft tissue diseases. And so age is a helpful friend for radiation oncologists. We seem to have fewer growth and developmental problems in patients that are radiated, and this gives us the opportunity to consider higher doses that we'll talk about. I think it's always important to remind ourselves that this is a multimodal treatment, and radiation is integrated sort of nicely into the middle of that package of chemotherapy with or without surgery, and there's really rarely an opportunity or a reason to consider a local treatment approach up front in Ewing's. So just a little background that I think that kind of frames the discussion of radiation oncology for Ewing's. The POG 8346 trial that Sarah Donaldson reported really quite a few years ago really demonstrated that, at least in the North American cohorts of patients, that surgery with or without radiation had a significantly higher local control rate than radiation therapy alone. There are obviously biases that may have been partially responsible for the reason for these lower local control outcomes. But the other important caveat to this particular data, that if you remember what was happening probably in the 80s and early 90s of the US, at least as far as radiation technology, there's very little 3D conformal therapy. Treatment planning was fairly APPA or wedged pair type orientations, and fields were drawn on X-ray images. So plan quality was identified as a significant prognostic factor in this particular trial, and that had, I think, an important sort of note for trials going forward. We looked at our data at St. Jude, where I practice, and have had a series of Ewing's trials over the years, also historic in nature in this particular data set. we've collected the tumor measurement and have used 8 centimeters for as long as I've been there, and obviously many years before that. And that's continued to show up as a prognostic factor in our data in these historic setting. Higher doses of radiation were also used. We actually had a period of time where we actually de-escalated dose below 40 gray for some patients with Ewing sarcoma, and that resulted in a higher local failure rate. And so I think standard doses of radiation in large tumors are important prognostic considerations. You know, the other thing that drives modality selection a bit is this concern of second malignancy. And in patients with Ewing sarcoma, that number isn't 0. It seems to hover somewhere around high single-digit percentages of 5 to 10%. There are some data sets that suggest it may be higher, but these two publications give us some examples. There's about a 4% risk at 10 years, and then secondary solid tumors seem to occur at a median of about 8 years, with the majority in a radiation field. And then this larger article here by Iyad Sultan that looked at over 1,100 patients, about an 8% risk at 20 years of any second malignancy. And again, secondary solid tumors out a number of years. And so significant consideration when we're thinking about adding or using radiation therapy. There are a number of factors, and we've discussed some of them, that impact local control. And so I'm going to highlight a couple of articles that are just large general reviews of big data sets. In the United States trials, I think one of the things that we've definitely seen that's happened over time from the earlier Intergroup 91 trial to our more recent studies is a move more towards surgery and away from definitive radiation. If you just add up the patients here, really dropping from about 39% to about 20% in that most recent trial. Pelvic and extremity tumors seem to continue to have the highest rates of local failure when treated with definitive radiation therapy, and the addition of surgery with or without radiation seems to mitigate some of those features. Overall local failure rates are between 10 and 20%, and I think the most favorable patients should be single-digit local failure rates. The Euro-Ewing studies or the CESS studies were also reviewed kind of in total, and I think the important contribution here was really the identification, again, in a large data set, that tumor size may play a significant role, and that's really colored a lot of our sort of views of Ewing sarcoma going forward. So local failure rates were again higher in the patients that were radiated, but I think what I really want to highlight here was that larger tumors, whether in the extremity or centrally, had a significantly increased local failure rate when treated with definitive RT, really almost doubling into the 20 and 30% range. When we looked again at this article just a second ago, I don't need to spend a whole lot of time here because we've really, I think, hit the highlight points. But I think the other key here as radiation oncologists is we've often lumped pelvic sites of disease all together and included sacrum with them. And I think we really do need to consider sacrum as a separate site of disease. Certainly a number of our retrospective papers from St. Jude have just put pelvic all together, and probably the mix of patients with sacral versus non-sacral may have actually biased that data a little bit. And so I think recognizing that sacral site, which is rarely resectable, is readily radiatable with relatively low morbidity and also excellent local tumor control, those patients need to be included separately when we consider changes in our local control paradigm. So I'm not going to make a huge case for radiating definitively large chest wall tumors because there's a lot of morbidity that may be associated with that, and I think we'll have a case to discuss at the end about that. But I think the key here is just focusing on one issue that we continue to see even today in our practice, which is the understanding that resecting chest wall tumors up front really is not the most ideal approach for local therapy in these patients. These patients benefit from a biopsy and then systemic therapy to significantly reduce the volume of treatment, and then really the modality of local modality can be decided at the time of local control, 12 or so weeks into therapy. And this paper by Dr. Schamberger clearly identified that delaying surgery really resulted in fewer patients ultimately requiring adjuvant radiation therapy based on a need related to surgical margins. And so The other, I think, caveat with chest wall patients, as we start to look at the outcomes for these, is that they're not all bad. And Danny Indelicato here, as one of our moderators, published a recent study looking at patients with large chest wall tumors. A large number of these, about 14, had gross residual disease at time of radiation therapy. I think as radiation oncologists, we're often concerned about the toxicities in the chest wall, including the heart and lung, and this demonstrates that even with high doses of radiation, relatively modest toxicity profiles are possible, with about 26% of patients experiencing a grade 3 toxicity and relatively few patients ending up with a radiation pneumonitis. And when you look at the lung DVHs here, these are probably a bit higher than what we might see in an adult lung cancer study in terms of what we would consider acceptable or tolerable, but in the pediatric population, this actually works out quite well. We looked at late effects in our chest wall sarcoma population that included both Ewing's and other non-rhabdo soft tissue sarcomas. And again, about a quarter of patients experienced a late grade 3 toxicity. There are lots of musculoskeletal toxicities in these patients, but they're not all directly attributable to radiation therapy. One of the things we were particularly interested in was seeing whether or not we could correlate doses of radiation across the vertebral column with the risk of scoliosis or kyphoscoliosis, and so we looked at those patients before and after treatment. We actually were not able to identify a significant predictor related to radiation that would yield a risk of kyphoscoliosis. Really, primarily surgery and the degree of surgery on the chest wall was one of the more significant predictors. So spinal sites of disease are in that axial area where surgery is often difficult to perform and radiation therapy is often the primary modality. This more historic series here, looking back at some of the European patients, did not identify significant prognostic factors like tumor volume or radiation dose, and the local failure rates were kind of typical with that era of about 20 or 25%. I think the important takeaway from this paper for me was really that in that era, it was difficult to treat patients with tumors around the spine to doses that we typically use for Ewing sarcoma, such as 55 or 60 gray. And because of that, there was a fair amount of underdosing right where the tumors were actually located, and we didn't see a dose-response relationship in local control. More recently, there have been a number of publications, and I picked this one here that was a proton experience for spinal and paraspinal Ewings. The local control in this particular publication is excellent. The doses to the target volume were 55.8 gray using proton beam radiation. And I think the important thing here from this article for me to highlight was really the doses that were acceptable along the spinal cord, were really max doses to very small volumes, albeit were on average of 50 gray to the cord, and in some cases point maxes were higher, even 54 gray. And so there were 15 patients that received over 50 gray to the spinal cord, and no evidence of neuropathy related to this treatment. And so in order to cure spinal or paraspinal Ewing sarcomas, we really do need to use the doses of radiation that we use at other sites of disease. And I think there's this growing evidence that you can do this safely without risks of myelopathy. And again, looking at pelvic sites of disease, we've talked about this a fair amount. This was an older paper from one of the earlier studies. I think the important thing here for me, since we've talked about this in a couple of different ways, was really that the addition of improved systemic therapy impacted radiation oncology outcomes. And so in patients that received VAC with IFOS and etoposide, so all of the active agents in Ewing sarcoma, they had a significantly lower rate of local failure. And so as we design trials and look at the outcomes going forward, remembering that systemic therapy can actually impact local control is important for us to consider. There have been a number of series of proton or modern era treatments for patients with treated with radiation therapy for pelvic sites of disease. These are often very, very large tumors, and historically these patients have fared less well with local control rates in the 70 to 80% range. Here, this example, treated all with protons, has an excellent local control of over 90%. And I think the most important thing here is also looking at the toxicities of these patients where they have relatively little GI or GU toxicity now that we've moved into this sort of modern conformal proton therapy era. We'll talk just a little bit about, and I think this will be a part of our discussion at the end, of dose selection and escalation. I think based on a lot of historic data that we originally showed, there looked like there was an opportunity for dose escalation in Ewing sarcoma, and that coincided with really sort of the implementation of sort of modern radiation technologies like IMRT in the early 2000s. We ran a small dose escalation trial at St. Jude in this population where we took patients with larger tumors and delivered doses of 64.8 gray as opposed to the conventional 55.8 gray. Our target volumes were GTV, which was the visible gross disease at the time of radiation, plus the initially involved bone, with the understanding that you might not see tumor, but this tumor didn't recede uniformly back in the bone, and so all of that was covered. And then we added a 1 centimeter CTV, and those were treated to these 2 different dose levels. And with that approach, the outcomes for those patients were really kind of uniformly excellent in this small institutional trial. I think one of the difficulties we did have is at that 64.8 gray dose level, where many of those patients were these large pelvic or axial tumor sites. We did have a higher rate of grade 3 or higher toxicities in that escalated dose population compared to the standard dose population, and many of those toxicities were musculoskeletal in nature. Dr. Lasker, who's here with us, published a nice randomized trial just this year in Ewing sarcoma, and we'll talk a little bit about that because I think this really provides the strongest evidence to date that potentially 55.8 gray or 54 gray may not be the ideal dose for all patients with Ewing sarcoma undergoing definitive radiation. There were about 100 patients in this trial and really had an excellent sort of uptake of randomization, which is encouraging because that's always difficult as a radiation oncologist to consider a dose escalation trial with a standard and a higher dose arm as far as how acceptable this will be to families. The dosing was 55.8 gray or 70.2 gray, and the tumor volumes are here. And Dr. Lasker, if I got them wrong, please feel free to correct me when we get to the discussion. But in general, a pretty standard sort of expansion of a CTV, and then for the escalated dose arm, then an additional 14.4 gray, really primarily to the gross visible tumor. The outcomes here really yielded a significant improvement in local tumor control for patients treated with this escalated dose compared to their standard dose arm. And I think overall the group is quite well balanced when you look at the 2 different cohorts. I think the other important factor here as we look at this is really the median tumor size, and also the range really extends primarily into what we would consider larger tumors in the US by that 8 centimeter metric. So really very, very few small tumors were radiated in this particular randomized trial. We'll talk just a little bit as we wrap up here about margins. And so I think one of the things that has helped drive these dose escalation trials and this consideration in Ewing sarcoma has really been both the integration of modern radiation technology and the gradual reduction in targeting margins for Ewings. And just sort of from a historic perspective, when you look back to POG 8346, where one of the questions was whole or partial bone irradiation, to where we are now, which is really gross disease plus margins potentially as small as a 0.5 centimeter. And with that, integrating imaging like MR and PET and pre-chemo imaging into these targeting systems that we have that allow co-registration of many, many images, we've really made, I think, great progress in reducing the volume of tumor that needs to be treated. And that, along with technologies like proton therapy, have really allowed us to deliver dose really just to the tumor while really preventing sort of collateral spill of dose to other normal tissues. I think I always talk about this type of slide when I give talks about radiation targeting. I think regardless of your treatment modality, 3D conformal, photon-based IMRT, or proton beam radiation, I think sort of understanding that the GTV is often some sort of post-chemotherapy visible tumor, and often the initially involved bone because of that difficulty understanding the extent of tumor left in the bone. And then the CTV is some anatomically constrained expansion around this. And I use this frontal bone Ewing's case as an example, where you see this soft tissue abnormality here that extends partially into the orbit, and then after chemotherapy, we have a significant reduction in that volume to where this is then mapped out as the GTV, and the CTV then extends around it, but doesn't actually extend into the orbit and doesn't include the eye because we didn't perceive that to be at risk. So that type of targeting really allows us to get away with these higher doses of radiation in these really large cases that might ultimately have dose spill out into critical structures like bladder or bowel or cord. So our current approach here is shown on the right. So tumors less than 8 centimeters, we deliver 45 gray to the CTV and then a boost to the GTV with a respective PTV margin or robustness parameter if you're using protons. And then those patients with gross disease that are over 8 centimeters, we deliver doses of 64.8 gray, again with the same original CTV. So with that, I think, I hope well, I know when we talk here in just a second, and you've seen from all of our presentations that really Ewing's has a diverse approach, a diverse series of sites, and really diverse responses to chemotherapy that really make this sort of concept of a standard best local therapy approach really kind of meaningless. I think multidisciplinary tumor boards or forums really yield probably the most important discussions about the best approach to local therapy for these patients. Limb salvage is extremely successful nowadays, and the functional outcomes of these patients are excellent. Limited margin radiation therapy or using this in an adjuvant setting also may be very, very helpful in our target of sort of an under 10% local failure rate. And then integrating modern imaging into this paradigm, which we do routinely now in our trials, has really helped, I think, yield these high rates of local control. I think we'll spend some time talking about dose escalation afterwards, and I think a number of the trials that are now getting underway will help us answer some of the questions on who is the most appropriate patient for radiation dose escalation and whether or not there may be a population of patients that could be dose de-escalated as far as radiation exposures. And so with that, I'm going to hop over to the other table. Thank you.
Thank you, Matt. Thank you to each of our speakers. As I said at the beginning, we have 3 exemplary cases that I hope elicit discussion covering a number of the topics discussed in the previous talks. So the first case is a 19-year-old boy with a Ewing sarcoma of the proximal tibia. He has aspirations to play professional football. Depending on what continent you're from, you can interpret that differently.
Is the team on the right a professional football team, Danny?
They are.
Okay.
In the United States, they are. This is his imaging at diagnosis. You can see a lower extremity tumor on sagittal coronal MRI, and then coronal CT on the top panel, and then an axial T1 contrast enhanced fat-sat image across the bottom. The patient received standard VAC-IE compressed chemotherapy, and here's his post-induction chemotherapy. Again, sagittal and coronal MRs on the top panel with a coronal CT post-induction, and then across the bottom panel, similar axial T1 fat-sat images. So non-metastatic, lower extremity, Ewing sarcoma in a teenager interested in functional outcomes long term. I'd like to open it up to the panel first for recommended treatment options, and then I'd also like input from the audience. So I guess I'll ask Demo first for the extremity tumor, what you'd recommend in this case.
Well, traditionally, we would recommend surgery. Surgery in this context would mean that we have to replace the proximal tibia. So if you see the coronal images of the tumor, it's actually it looks like a very nice tumor to operate. It does not infiltrate a lot of the tibia, meaning that if we do a megaprosthetic replacement, we can have a small implant put in there, which is associated with a better functional outcome. The problem is that when we go to the axial images, and especially into the axial images at diagnosis, we see that the tumor, unfortunately, although it's very small, has already contaminated the interfibular tibia joint. So we will need to either resect the proximal fibula as well to be sure that we have addressed the complete volume of pre-chemotherapy extension, or we will need to do post-operative or pre-operative radiotherapy. Now, the combination of megaprosthetic replacement in the proximal tibia and radiotherapy is pretty much an orthopedic oncologist's worst possible dream, because we know that the complication rates in proximal tibia are high as they are in any case, and if we add radiotherapy to the mix, it goes to pretty much catastrophic. So in this patient, I would have said that the first option I would discuss with him would be surgery, but I would also be very clear up front that even with a small megaprosthetic replacement of the tibia, the probability of going on to do professional sports is, if we are honest, 0.
Dr. Crazen, Dr. Lasko, Dr. Calvo, any contrary opinion or additional insight?
Yeah, I don't know if it would be contrary. I think we would have that same discussion in my clinic that I think the overall likely function for sort of day-to-day life of some sort of surgical resection would probably be the most ideal. It also wouldn't carry with it the likelihood of any secondary risks, such as secondary cancers long-term. I think that sort of hybrid approach, like you described, would actually carry maybe the most risk, that you could wind up with wound complications or prostheses or metal not adhering to bone or things like that. We have, I think, relatively little experience in North America radiating cases like this. And while I think it is small and the child is not really a child, they're an adult, I think there still could be some longer-term risks of fracture when you wind up delivering sort of curative doses of radiation. We found 60 gray was kind of our breakover point for kind of the soft tissue sarcoma, bony sarcomas. I think the Ewing's patients do a little bit worse just because they have this added insult of tumor actually in bone. And so that would also be my concern, is that you would wind up with some sort of a prosthesis or metal in place anyway after you fractured it. And so I think we would work very hard to push this family towards a definitive resection as opposed to radiation.
So that's no radiation at all, no pre-op or post-op is ideal. Okay.
I will spend quite a lot of time trying to understand to what level his aspiration is to be a sportsman professionally, and I will make very clear to him that the reality is that he's not going to be. So he has to adapt to the new situation. Surgery would give us another important piece of information, which is the histological response and how the patient is going to behave later on. And there is an opportunity for intraoperative electrons here. When they remove the bone, the tissues themselves, you can expose them to the boost. I have not done it alone. I have done it as a boost and then moderate external beam radiotherapy. But I would probably, in this case, I think it's a great responder, and surgery alone is a very good management for her.
Thank you. Does anybody from the audience have additional perspective? Yeah. If you could come to the microphone, please. And please introduce yourself for everyone as well.
Hello, Uta Dirksen from Essen. I just would like to share with you, we had a kind of similar patient. It's Germany, so it was soccer. But really going up like in Bundesliga and stuff. And this guy has chosen amputation, because his life was sport. at that time. He could, of course, he's not playing soccer now, but he does other sport. But as an amputee, you have a kind of lifelong guarantee that your rest leg will function, and this is what he has chosen. And from him we learned that, especially in those types of person, we really also discuss this, and he's also like a role model, so he would come to our hospital and talk to other people and see what you can do for this. So he's like a Olympic type of person now, and just also to drop this here, that this could be anyway also an option.
Thank you. And I think that raises a good point. Just because of the age range of the typical Ewing's patients, they might not be fully autonomous, but they have a great deal of agency and can have input into their own goal and aspiration and treatment, as opposed to, say, a 4-year-old rhabdomyosarcoma of the extremity. So those are all important considerations in this population.
Danny,
Yes.
can I just add a point to what everyone has said? In our institution, although we have a randomized trial showing improved local control, but we would still go by what the other panelists have said. We would go by, if possible, surgery followed by post-operative radiation therapy. But my question was something different. We talk about the complications of post-operative radiation therapy with megaprosthesis. My question to the surgeons is, how strong is the evidence that there is an increase in post-op complications or loosening of the joint with post-operative radiation therapy?
Loosening of the joint, to start with that point, is not really what we are worried about, because the megaprosthetic replacement of the proximal tibia always has a hinge mechanism which cares for the stability of the joint. The problem is that we have, either with pre-op or post-op radiotherapy, a much higher probability of infection. So for megaprosthesis, we know that the probability of long-term infection is about 10 to 20%, and the proximal tibia is one of the sites where we are at the higher range of that, so about 20%. Of course, if you ask for evidence, we only have retrospective studies, which is the point, but these retrospective studies also sort of confirm our clinical experience. It's always very difficult to do a good replacement of the proximal tibia, because you have the bone under the skin, so we always need a muscle flap to make sure that the prosthesis is not going to get infected. We do know that there is at the moment no prosthesis that's going to last for 40, 50, or 60 years. So in a very young patient, we also need to take into consideration that we're going to have many revision surgeries. Each revision surgery is going to be associated with a higher risk of infection, all data that we have shown repeatedly in retrospective analysis. And we also know that if we do preoperative radiotherapy, we have a high risk that the wound is not going to heal primarily, leading to a very high risk of early infection. If we do post-op radiotherapy and have to go back in there for any reason whatsoever, we are going to have, at that point, a very, very big problem, which is why we are very aggressive in trying to avoid additional radiotherapy if the patient does not need it, which is why I said I would be much more comfortable resecting the proximal fibula, because for the functional outcome it wouldn't make any difference whatsoever, but I would do really everything to avoid the necessity of post-operative radiotherapy in this setting.
Excellent. Go ahead, please.
Hi, this is Bilal. I'm from Aachen University in Pakistan, so I have a question regarding surgery. So provided this patient achieves an almost a complete response radiologically, there's good response that there's no evidence of disease on the post-chemotherapy scan, could we potentially spare getting into the joint surgically and avoid a prosthesis?
So we are talking about, just to be clear, we're talking about a very, very, very different scenario than the one we are seeing right now. So we would have a complete response. If we go to the images, thank you, Danny, for a diagnosis. Yeah. If it was an osteosarcoma, I would maybe consider it, although to be honest, if you see the axial CT, the coronal CT scan on the right-hand side up there, I would have to resect just below the joint surface, meaning that the reconstruction I would have to do would be very, very at risk for failure. So I don't think that would work in this case. But if we take a tumor which is a little bit further distally on the bone, and if we had an osteosarcoma, where I know that the tumor is very good delineated in pre and post-op chemotherapy MRIs, then I might consider it, yes. For Ewing sarcoma, we do see that we need a larger margin in bone to make sure that these tumor cells, which appear to grow beyond the macroscopic extension of the tumor, also get resected. Remember that we said we want to avoid radiation therapy in this setting. This is also the case if we spare the joint. So for a Ewing sarcoma at this location, or even a little bit further distally, I would be extremely reluctant to discuss this.
Thank you.
Thank you. Move on to the next case. This is a 9-year-old girl who presents with severe dyspnea and cough. It's not COVID, but that's unfortunate because it's this. What you see before you is a coronal CT of the thorax and axial images at different levels on the left side of the screen, showing a large mass with malignant pleural effusion. She receives induction chemotherapy and has a pretty good response. You can see the gross disease is largely now limited to the apical aspect of the left hemithorax, but still with some posterior nodularity and pleural studding here at different levels on the axial. What treatment would you recommend? We'll start with you, Dr. Crazen, since you showed some chest wall slots.
Yeah, so maybe just go back one image, Danny.
This one?
Yeah, and I don't know if she has bone marrow disease or bone
She
mets,
doesn't.
but
She doesn't.
it's-
Just that malignant pleural
it's
effusion and
just
pleural
the
study.
effusion. Yeah, so in this scenario, we would still discuss with our surgeons whether there was some feasibility of resecting the primary site mass. I think the pleural disease has bought this kid radiation, but anyway, to make it easier to deliver that, and in our institution, I'll tell you in a second, we would do whole pleural surface radiation for this site. But anything that would reduce that additional dose that we need to give, particularly in this case, because we'd count this as a large tumor, so we'd feel somewhat obliged to deliver 60 to 64.8 gray to that site. We would look for resection, and so it doesn't have to be a perfect resection in the sense that you're really not interested in margins because you're going to be radiating there anyway. But just getting in there and taking out that visible disease and the couple of ribs it's attached to would probably facilitate radiation. And then in that postoperative setting, we would deliver whole pleural surface RT. Do that with IMRT with a photon-based technique. And have usually aimed for 30 gray. It's not a perfect coverage with that approach. You wind up with areas that get a little bit less and some areas that get more. But it seems to be fairly tolerable at that dose level. And then if you needed to, for margin regions or histologic response regions, radiate the primary site, it's fairly easy then to continue to 50 gray, which would be our post-op dose.
Got it. Anyone else on the panel have commentary? Go ahead, Dima.
So, full disclosure, I'm an orthopedic oncologist, so this is not exactly the typical area where I'm surgically active. And I would also like to point out that this is a very good case where I think we would have presented the facts at the Study Central office in Essen. They have an excellent interdisciplinary tumor board for very challenging cases. And they have also shown that the recommendations that they have a very positive impact on both local control and patient survival. So that's what we would have done in any case. But if I had to talk to the patient before I got the recommendation of the study office, I would consider also for the following aspects. Perhaps I would want to discuss with my radiotherapist about pre-op radiotherapy, because one of the things that we have to consider here as well is that if I remove probably at least 3 ribs at the upper thoracic wall, perhaps even 4, then I would probably need some sort of reconstruction, and we know that the reconstructions options that we have at that point are also not very stable. So if we had the possibility to do pre-op radiotherapy of the big mass on the apex of the thorax, perhaps reduce it further, and then go on perhaps at the end of treatment and remove the residual mass that's probably going to be even be there, then from a functional and reconstructive aspect of this of the local treatment, I think we would have a better result. The obvious disadvantage is that we won't know how the tumor responded to neoadjuvant chemotherapy. We have data from the Ewing 2008 and the Ewing 99 study showing that a poor histological response can be salvaged in terms of prognosis if we do high-dose chemotherapy. So again, as I said, this is something that we would coordinate very, very well with the study office. But for me, I think this is a case, if we discuss surgery, we would be a strong advocate for pre-op radiation therapy.
Thank you.
Danny, can I add just
Yeah,
quick point? In our institution, we would probably push for surgery with a reconstruction. And that is what we've been following. We do a custom-made reconstruction of the defect, and then we would back it up with radiation therapy to whole pleura, followed by a boost to the primary site of disease to a dose of 45 to 55 gray based on the residual disease that is left behind.
Well, this is good because this patient was treated differently, and we have a different philosophy. We treated the patient with definitive radiotherapy just because it's unusual for us to knowingly subtotally resect the Ewing sarcoma. That is, remove some of the tumor and leave behind gross disease. And as indicated on this slide, this tumor, even if you remove the apical mass, you would still leave behind gross disease. And the combined modality therapy of a large chest wall resection and reconstruction entails quite a bit of additional morbidity beyond the unimodality of definitive radiation. And in terms of the volume radiated, we still do, in patients with malignant pleural effusion, real hemithorax radiation, not just the pleural surface, because I just imagine with the tumor cells floating around every aspect of the lung and adjacent to the mediastinum, that area is still at considerable risk. Now those interventions, the hemithorax followed by definitive radiation, means that this patient had a really high lung dose, both ipsilateral and combined, by every metric. So they would be at risk of radiation pneumonitis, and that's a serious consideration. But I think that based on our outcomes, maybe the benchmarks for radiation pneumonitis in kids, even ones that receive multimodality and multi-agent chemotherapy, tend to be surprisingly good. So we probably treated this patient 3 or 4 years ago, and she's doing well, but she's not out of the woods yet in terms of control or definitely toxicity. Before I go on to the next case, because this can be treated so many different ways, I'd like to know if the audience has any input on a case like this. Well,
So Dr. Daniel, what was your dose to the hemithorax?
15 gray at 1.5.
Okay, so
And when we do that, we'll do it using either VMAT or IMPT, and use a dose painting technique where the gross disease is getting 1.8.
yeah, so that's my question is regarding the COG strategy to go up to 12 gray in less than 6 years and 15 in more than 6 years,
Correct.
and then the St. Jude strategy to a higher dose of 30 gray. So do we have some data to support that we go for a higher dose, and if post-operatively we have to irradiate the pleura, would we still go for 30 gray if it is completely resected? I know this would have been a difficult one to completely resect, but if we could consider lower dose to the hemithorax in the post-operative setting.
Yeah, so I guess in cases where, like this, where there's obvious pleural disease, or a surgeon has biopsied pleural plaques when they've done the resection, and you know that there's definitely true contamination there, we have always tended towards that sort of 30 gray range. Some of that's just based on truly the feasibility of getting, you really can't get a lot more dose in and be comfortable with, or we can't get comfortable with our lung DVHs. As sort of an aside, you end up with about 15 to 20 gray to the whole lung, to that lung anyway. So I think you kind of do what was already done in sort of the simpler hemithorax irradiation, papers, and so whatever benefit there is to radiating that lung, it probably is done. Yeah, I think we would also probably consider boosting like some of those nodules if they were visible, and again, like an approach like VMAT in the post-op setting, or something, you can usually drop some dose in on those areas. So.
Just one short comment. I will introduce the use of PET-CT to guide radiation therapy volumes, radiation therapy escalations, radiation therapy evolution in the future.
And perhaps just one point, because you said very, very correctly, everyone should be not only reluctant, but if you can't do a complete tumor resection, we have extremely good data that show that you don't need to do any resection whatsoever. So that's a very important point. The only thing I would at least throw into the mix here is that the question is about definition. Do we have a primary tumor which is multifocal? So if I resect the large mass, I have removed only part of the tumor, or do I have in the post-induction chemotherapy images signs of regional disease spread, so pleural disease spread which is not associated with the primary tumor, in which case at least you could discuss the resection of the tumor. And I think with this image that you're showing, it's extremely, extremely difficult to know what's the case. So it's more or less a question of philosophy and definition.
Yeah, I agree. Any other additional input from the audience? All right, we'll go on to the last case. We have a few more minutes. So this is a 17-year-old male with right leg pain prompting a workup. He's ambulatory without much difficulty. Plain film shows a lytic lesion in the right iliac crest. It involves the iliac wing on MR and PET-CT. Difficult to determine if it invades the sacrum. There are no metastatic disease in the bone or bone marrow, but several small pulmonary nodules. Again, dose compressed via CIE with a partial response. CT is done with 3D evaluation of blood supply and bony involvement on reconstruction, and a post-induction imaging is shown in the lower panel here. And based on that, he underwent surgical resection via right internal hemipelvectomy. The surgical, well, you know what? I'll stop there and elicit comments, and then we'll go on to how it's done.
Oh, definitely, there is an opportunity here for intraoperative electrons. The medial margin, the central margin, both vascular and the sacrum, is too close to the lesion itself. And that component of the dose will be always helpful. I mean, it will help in the external radiation therapy design and so on. So this is one case that, at least in Gregorio Marañón, will be discussed in the tumor board. And probably what we say is that we schedule the patient to the operating room with electrons. And then we make a decision. But once you are scheduled, probably you are going to get electrons.
Would everybody do surgery in this setting?
Well, we did, so it's my case. But yeah, and he really was. They were considering really an iliac wing resection, so he wasn't going to lose his joint or anything like that. We thought the joint was clear. We spent a lot of time discussing this case back at home at St. Jude. I think most of our focus was on that margin there and the likely need for postoperative radiation therapy, and then kind of, depending on which pelvic data you buy into, there's lots of particular reasons you might. The other difficulty is he was incredibly functional. He was a son of a farmer. He was likely to go on farming, so he was likely to do some outside work where being ambulatory was going to be fairly important. And so, we didn't want to hurt that. But on the other hand, he was also, I think, 17 or 16. And so, full grown, he wasn't going to wind up likely with some sort of leg length discrepancy or anything like that. And it's pretty peripheral from, bowel bladder. And that's a great proton case because you can keep dose away from all of the internals, basically. So go ahead.
So Matt, you knew that this patient would need postoperative radiation going into it because of the possible SI joint involvement or just concerns at the margins.
We believed that would be fairly likely the case.
And
Although I think they're probably on the pediatric oncologist side was still some hope that this might come out and no radiation was needed. I think that's sort of the ultimate goal of an iliac wing Ewing's resection is to not need any RT.
And I'd like Dimo's opinion on this too. You talked about the importance of functional outcomes. So your thinking was that surgery plus radiation would have a better functional outcome than radiation alone?
No, functional outcome is very important as soon as we guarantee local control. We have, at least in the Ewing database, a lot of data which make us comfortable to say that these are tumors that benefit from combined treatment if you go for surgery. We cannot answer the question about definitive radiotherapy because so few patients in our database have received definitive radiotherapy, but we do know that if we do surgery, the patients are going to benefit significantly from additional radiotherapy. From a functional perspective, definitely not, but from a local control and overall survival, yes. The thing is that, and I think that's what Matt was alluding when he said, depending on which data you buy into, the analysis that we performed from the Ewing 1990 data also showed that the more aggressive surgical approaches in pelvic Ewing sarcoma were associated with significantly higher local control and overall survival probabilities, meaning that in this case, I would really be extremely reluctant to spare the acetabulum. Yes, you can do it, but you will need to have at the very, very least a huge radiation field to make sure that you covered everything that you showed on the initial scans. If you could go back one slide showing the tumor representation, this is also a tumor where I would say we see some disease in the posterior aspect of the iliac crest. So if I leave the functional outcome out of the consideration, this is a patient where I would actually say I would do a complete internal hemipelvectomy, removing the complete ilium, acetabulum, and at least parts of the ischium and pubic bone, but also removing parts of the sacral bone on the other side of the sacral pelvic sacral fuge, because the tumor appears to have infiltrated at least the capsule of that joint. Of course, the functional outcome is going to be much worse. We are talking about definite limb length discrepancy and so on and so forth. And this is something that we would have to discuss with the patient, but that would be the only approach I would feel very, very confident about. And additionally, radiotherapy in any case.
So if I ask the panel in the hypothetical future where we could say the local control and survival is equivalent with definitive radiotherapy in this setting, would your recommendation be the same?
We assume that this is equivalent?
That not only survival, but local control is equivalent with definitive radiotherapy and combined modality therapy.
I will use combined modality therapy with protons, and I will try to avoid surgery.
Okay.
So in our decision-making process, in our disease management group, what we would do is we would first look at if surgery is possible or not. And then we would also look at the possible morbidity of surgery. And that's where we would look at what kind of surgery is being planned, whether it's a type 1 only or a type 1 and type 2 hemipelvectomy, which includes removal of the acetabulum. That would cause a lot of significant morbidity. In that situation, we would consider for definitive radiation therapy. So in this case, very likely we would have done definitive radiation therapy because of the extent of disease across the SI joint involvement, and you would possibly also need a sacral resection of the sacral ala in this case.
Yes, that's what. If you do surgery, yes, I would go for resecting the lateral part of the sacrum as well.
Yes.
And again, definitive radiotherapy. If we buy into the hypothetical scenario, if I have good data showing that it's equivalent, then for me it's a no-brainer. Then I would say, okay, by all means, I don't want to do surgery there. Please do something else.
Yes. So both in terms of disease control and in terms of morbidity and functional outcomes in this patient in our institution, we would have done definitive radiation to escalated doses.
Okay. I'll let Dr. Crazen finish with the surgical path and as it was managed, and then we're getting the red light, but we'll take some questions because I'm really interested in audience input on this case too.
So as this turned out, yeah, he underwent sort of an iliac wing, and that sort of lateral aspect of the sacrum resected, spared his sort of acetabular complex, and they got clear but very close surgical margins. But the disappointing thing was the fact that even despite some shrinkage, there was 90% viable tumor. And so we spent some time discussing, and actually after today's meeting, I think I feel a little bit stronger in my recommendations for post-op RT. We've usually based poor histologic response as one of the primary reasons, but I think even pelvis in general is just looking like a reason to add adjuvant radiation with a big resection. And like Dima pointed out, the target volume is large in this particular case. There's a large sort of operative defect, lots of areas where you could tell the surgeons were, and that initial extent was also big. And so it's a pretty big 50 gray volume, and he's getting treatment now. So,
Question?
Rajkumar Venkatramani, Baylor College of Medicine, Houston, Texas. One comment is it's reassuring that everyone has a different opinion. There is no definitive opinion, each one of us. And
I don't think that's reassuring to our patients.
but reassuring to me in the sense, initially when I listened to the 3 talks, I thought, oh my God, what we are doing is wrong in Baylor College of Medicine, because we are not doing any of the things they're told in the talk, right? We rarely do combined modality treatment in our institution. And the question here is, as a pediatric oncologist, I know local control is important, everyone is focused on it, but no one is discussing that the patient has lung mets. And how does that influence what you're going to do in this patient, right? So if it is localized disease, then it's a different decision process. But if a patient with metastatic disease with potentially poor prognosis, our decision, I can tell you how we decide, right? So the prognosis is relatively poor. So we actually go for radiation therapy in these patients, because from our point of view, surgery has acute morbidity, radiation has more long-term morbidity. If the patient is not going to live 10 years, 20 years, we'll rather take radiation and make him functional. And we're also concerned about doing surgery and recovery period and delay in chemotherapy, those kinds of things. Those things, I didn't see that discussed in the thing, because when you do heroic surgery, reconstruction, sometimes that causes delay in therapy, and that can also affect prognosis for the patient.
So I think we treat lung-only metastases, which is what this patient had, more along the lines of localized disease. And if this child or young adult had bone or bone marrow disease, I think we would probably have fallen heavier on the radiation as definitive therapy.
But there would still be an interruption in systemic therapy in the presence of gross disease of variable time depending on post-operative complications.
On that, we have analyzed the data of the Ewing 99 study. We want to avoid treatment delays in any case, yes, And because we have shown very clearly that these treatment delays are associated with a poor prognosis, but we have become very, very aggressive with the induction of consolidation chemotherapy, even in patients who have active treatment of complications. It is difficult for the surgeon, but it's possible. And so we've now gone over to having patients that have no delays, even if they have complications. And we use these vacuum-assisted closure systems, give them chemotherapy, and then try to coordinate with our pediatric oncologists when we expect the lowest leukopenia, to avoid changing the vacuum dressing at that day, but coordinating around these expected leukopenia days to make sure that the patient is still getting both surgically and chemotherapeutically treated. That's the first aspect. The second aspect, just the question I want to say is, I don't have the answer to that, but I would like to point out one thing. It's again a philosophy question. If you have a patient with poorer prognosis, then you can always argue for two things. You can either say they have poorer prognosis, so I want to do a treatment which is not so effective in order to spare them the long-term morbidity, the morbidity of, say, surgery. But you can also say these patients have a poorer prognosis, they have a higher risk. There might be an argument to be even more aggressive in your approach to get the best possible outcome for them. Is it the right way to go for all patients? Definitely not. But as Dr. Krasen said, we have a survival probability of about 50% in lung metastasis only. And I think you only get it if you do the best modalities for local and stem control, rather than if you are a bit more conservative in your treatment.
Leo?
Actually, I have a comment. Yes.
Yeah,
I have a comment
Leo.
about
Okay.
the last case. Actually, this complicated case, I think the patient's himself opinion and the parents' opinion is very important like case, because doing this disfiguring surgery will affect the quality of life too much. So providing good radiotherapy for this patient without doing surgery, even it may be less, the survival rate and event-free survival will be less in radiotherapy alone. But I think the quality of life for these patients is more important than being live but with disfiguring. We have a patient in Jordan. The parents and the patient himself refused to do the surgery, like hemipelvectomy, and received radiotherapy only. And fortunately, he's now finishing a university, and she married, and she is living a very good life. While if she did this disfiguring surgery, maybe now she's in her bed. Thank you.
Thank you. And we'll do one more comment from Leo, and then I think we have to close this out before we get kicked out of the room. And I'm never invited back to moderate again.
Leo Mascarenas, Children's Hospital, Los Angeles. We recently published the Children's Oncology Group Phase 3 data, which really showed outstanding local control with either modality or both modality. There was no difference in outcomes. And if you look at the Kaplan-Meier curves for event-free survival, including local and distant metastases, even though not statistically significant, the lowest bar was actually the patients who got combined surgery and radiation therapy. And to me, that suggests that there is a big component of biology rather than local control modality in these patients. And so I think the key over here, critical need is expert multidisciplinary care for these patients. And in a patient like this, where you actually, my personal bias, and this has changed over time, even looking at the literature, is, it's really important that we actually have good studies which are prospectively going to evaluate functional outcomes in these patients, so we can be better informed in our decisions for local control therapy. And so my plea to both the Europeans and the North Americans and everybody else is to really consider this, especially since local control has gotten so good in these particular patients, that we really have to focus on outcomes. And I agree, patients with lung-only mets are curable, and so it's also critical from that standpoint to understand functional outcomes. And I have several patients who are treated with surgery alone, and then I've got pulmonary radiation who are long-term survivors but have significant morbidity, and I have patients who've been treated with radiation therapy alone with pulmonary metastases who are competitive skiers in the Winter Olympics. So that's what I wanted to share. Thank you.
Thank you. Thanks again to our speakers. Thanks for the audience for letting us run late. And people will hang around for additional questions if needed.
Yeah, so.